I was speaking with a physician client recently about one of their cases. This is a crashing patient who was managed, I would say, incredibly well, but the physician had lingering doubt as to whether the resuscitation was good enough, and by extension, whether they were good enough. And let's be honest, very few physicians are immune from this kind of doubt or immune to this kind of doubt. Could be every now and then, could be every single day. Maybe it's a facial laceration, did your best undermining and debriding, etc., but that result wasn't perfect. Plastic surgeon probably could have had a better result, or there's a patient with a comminuted distal radial fracture, and your reduction was maybe good enough. What is ortho going to think when they see this? They're going to,
Oh my God.
who knows? Now, my client's case, we're going to get back to that in a moment. But first, I'm going to talk about Bon Jovi. John Bon Jovi. Long hair, arena rocker, laid it in the 90s and early 2000s. You give love a bad name, I'll be there for you. The hits go on and on. For a long time, there was nobody who could touch Bon Jovi's power and his delivery in arena rock. Now, he might not have been everybody's cup of tea. Nobody, everybody's cup of tea. But there was no doubt that the guy could sing. He was 100% all the time. And there's a documentary about him, I think, on Hulu. It's about his comeback, making this comeback tour. And his voice just wasn't quite there. He could get kind of close, but you could tell he wasn't what he used to be. So, John Bon Jovi, his voice not quite hitting the high notes, went to an ENT and had a scope of his vocal cords. And they were not quite touching. Anatomically, Bon Jovi was not the Bon Jovi of old. And despite all of his best efforts, and let me tell you, he tried mightily to fix his voice with neck lasers and exercises and even surgery, he couldn't recreate his tone. The best that he could get was 80%. And in his words, my best is now 100% of 80%. Now let's hold on to that concept of 100% of 80%. And I want to get back to the critical care case. The crashing patient. They were super sick. They were most certainly not operating at 100% capacity, 100% physiology, maybe 50%. The best any doctor could do with their resuscitation was get to 100% of that 50%. But sometimes what gets into people's minds is, at least subconsciously, I need to resuscitate to 100%. As in, I will only be successful if I get this patient to mean arterial pressure of X or oxygen saturation of Y. And when you're dealing with an incredibly sick, crashing, unstable patient, you often can't get there. Well, at least in that early resuscitation, despite all of your efforts, despite your amazing clinical acumen, best you can do is 100% of 50%. But what many people see is that if they can't get the patient's blood pressure or oxygen saturation to a certain point in that early resuscitation, they somehow failed. And that's just not the case, because sometimes it's just not possible. And the inner critic feeds on this like it's at an 8-course meal at a Michelin star restaurant. And this is what's called maladaptive perfectionism. Now, the term perfectionism gets bandied about quite a bit, and it's spoken of as this burdensome trait. And maladaptive perfectionism, I mean, you can guess by the name, is absolutely a burdensome trait. It's an impossible load to carry. It is an impossible standard to live up to. Now, there is also adaptive perfectionism that we're going to get to in a moment. But first, maladaptive perfectionism. That is what most of us have, most of us carry. what fuels most of our inner voices, especially if you're achievement driven, which so many of us are. Maladaptive perfectionism is outcome oriented, meaning if a certain outcome happens, I'm okay. Or I will only be okay if this outcome happens. I will only be okay if I get an A, or I will feel good when X happens. The problem with that is that outcomes are not entirely within our control. What's within our control? Our values, judgments, opinions, and initiation of action. I say initiation of action intentionally because we can start a process, but what ends up happening in the end, there's so many other factors that determine the final result. And if our valuation of self is determined by something outside of our control, that's a recipe for misery. It's also one of the foundational elements of imposter syndrome, of inner criticism. And this is where my client was winding up. I am only good if I can get this patient to 100% perfect resuscitation. What? Wait, what does that even mean? What does perfect resuscitation mean? If it means that I have to get to X number, X physiologic parameter, then that's maladaptive because it might not be physically possible. What's the problem with maladaptive perfectionism in physicians, though? I mean, isn't perfect what we're shooting for? Maladaptive perfectionism is big time connected to physician burnout. Lots of studies, including this one and this one and this one, show that maladaptive perfectionism may push us to achieve, but it's not a recipe for thriving as a human being. It is not a recipe for thriving in a clinical practice. So let's talk about the other side of the coin, and that is adaptive perfectionism. And this one can be much harder to really embrace. I think it's easy to cogitate, it's easy to grok, it's easy to understand what it is, but to live it, incredibly hard, which we'll get to. Adaptive perfectionism is the perfectionism of process. Our process is something that we fully control. Adaptive perfectionism is focused on the self. What are the things that I control here? And am I doing those things to the best of my ability? Adaptive perfectionism sees that a perfect outcome, oh yeah, that is an ideal. It is an aspiration, but it's not an expectation. And the opposite of that, those things get switched in maladaptive perfectionism, is that the perfect outcome becomes the expectation rather than the aspiration. Now, it's easy to say, okay, just switch from maladaptive to adaptive perfectionism. Switch. Hey, no problem. Shazam. And you're going to be okay. Not so fast. Not so easy. Our maladaptive perfectionist cells are almost always on patrol. Maladaptive perfectionism is something that my coaching partner, Scott Weingart, and I focus on a lot in our Flameproof Anti-Burnout course. And it's something that I work on with almost every one-on-one physician coaching client. And I say all that because I want to just set the standard that it is almost universal. If you hear yourself in anything I'm saying here, just know you're not alone. This is pervasive. The exception is to not feel this way. And taming our inner maladaptive perfectionist is lifelong hard work because we get so ingrained with the idea of achievement equating to worth. And ironically, are often dissatisfied with the achievements once we get them. And that's well established in the perfectionist literature. You know, it's the grade that defines us. It's some external review that defines us. It's this patient satisfaction score that defines us. Comparison defines us. We know that those are all recipes for anti-joy. Comparison, as they say, is the thief of joy. So going back to the case, asking what are the things that you did in your process for resuscitating this patient? What were the tools that you used? What was the thinking that you went through? How did you communicate? How did you ensure that what you had done had reached its practical endpoint? And then you needed to move on to the next step. And when we teased it apart and analyzed it from a process perspective, it was indeed a perfect resuscitation. The thinking was, the medications were, the resuscitative measures, the IV fluids, the vasopressors, the non-invasive ventilation, the this, that, the positioning, the communication. You often can't fully control whether a patient lives or dies in the end. Sometimes you are there to do your best and bear witness to their final heartbeat. You can give them the best shot that is process focused, but the final outcome, often that is not up to you.